Uh, Good afternoon, everybody, or good evening, shall I say? It's at 4 now. Welcome to the meeting today on the 17th for a talk that's being done by the team at Wits University on hemolytic anemias. I'd like to especially welcome Professor Coetzee who's going to give us a talk on insane in the membrane, focus on disorders of the red cell membrane with Dr. Garrick Loudon. Prof. Coetzee graduated with a BSc and a BSc honors degree in biochemistry from the University of the Witwatersrand. She worked as a researcher scientist in both Austria and Germany, and then took up a position at the SAIMR and obtained her PhD from Wits. She did postdoctoral research on red blood cell membrane disorders at Tufts University School of Medicine in Boston, USA. She returned to South Africa to head the red cell membrane research unit and elucidated the molecular basis of inherited hemolytic anemias in Southern Africa. She subsequently shifted her research focus to the malaria parasite and was a founding member of the Wits Research Institute for Malaria. A special welcome to you, Prof. Coetzee. And Dr. Garrick Loudon has spoken on this forum before. He's qualified as a specialist physician in 2019 and became a clinical hematologist at the end of last year. He's currently working as a hematologist at Baragwanath Hospital and at the University of the Witwatersrand. I'd like to just give you some housekeeping rules, or shall I just introduce Heini as we are on the talk? Dr. Anaemia is also working currently with us at Baragwanath Hospital. She qualified as a specialist physician from Wits University in 2020. She's currently a fellow at the university, although she's actually got an exam, so she's a full-fledged clinical hematologist and currently working with us. Just a few housekeeping rules. You can find recordings of this talk as well as previous talks on www.bloodessay.org.za. Please don't forget to add questions to the Q&A section or put your hands up at the end of the session. CPD points will automatically be submitted to the HPCSA for everybody who's come on as under their own names, please. And there is an anonymous feedback survey at the end of the meeting, which we'd appreciate everybody completing. So without further ado, I'd like to ask Prof. Coetzee and Dr. Loudon to start the talk on insane in the membrane, a focus on disorders of the red cell membrane.
Okay, thank you. Yeah, Garrick is going to start.
Thank you, Dr. Philip, and thank you, Prof. Coetzee as well, for joining us. So this is case one. Case one is of a 19-year-old female. She presented initially to Sebokeng Hospital with an acute history of abdominal pain, which was localized to the right upper quadrant. There was no associated fever, and clinically it was noted that she had yellowish discoloration of her sclera. She had no travel history, and she had no history of recent infections. She was unable to recall her neonatal pediatric history, but she remembers that her mother told her that she was born with yellow sclera or yellow eyes at birth. In terms of her past medical history, there's no relevant past medical history, no relevant drug history, and she was receiving folic acid supplementation. So just on clinical examination, she was noted to be jaundiced with conjunctival rim pallor, and she had right upper quadrant tenderness with no obvious palpable gallbladder, and she had a 9 centimeter splenomegaly. In terms of her investigations, Just of note was that she had a hemoglobin of 8.1. She had a reticulocyte count of 17.64 with a markedly elevated RPI of 5.6, so greater than 2. Her LDH was 397, and she had an unconjugated hyperbilirubinemia as well. Just of note is that her Coombs was negative. She had otherwise bloods that were done, G6PD levels were normal, and relatively her other blood parameters were preserved. So in terms of investigations, examination of the peripheral blood morphology, apologies, it's not the actual patient's peripheral blood smear, you're able to see that contextually there's a number of red cells that appear to be smaller in nature, and appear to be contracted with a lack of central pallor. And these cells would be regarded as spherocytes. So just in these regions here, you can see the cells that appear to be spherocytes with this lack of central pallor in the cells. So just in terms of further investigations, she was also seen by our surgical colleagues. They had noticed that this radiopaque lesion that was noted on plain abdominal X-ray, and on further imaging, on CT scan imaging, this gallbladder or the gallbladder stone was noted. Unfortunately, it wasn't a porcine gallbladder, but it was a large calculus within the gallbladder. So in terms of her further investigations with the spherocytes that are present on the peripheral blood smear, the history of hemolysis, the gallstone disease or cholelithiasis, there was a test performed in order to rule in possible hereditary spherocytosis. And this specialized hematology test, the hypertonic cryohemolysis and immunophenotyping, was suggestive of hereditary spherocytosis. So in summary, a 19-year-old female with a hemolytic anemia in keeping with hereditary spherocytosis, and this was complicated by cholelithiasis, so gallbladder calculus, as well as cholecystitis. So just to look at some of the cases of hereditary spherocytosis from Chris Hani Baragwanath Hospital, although we were only able to find about 6 cases from the past 10 years or so, the average age of presentation was 29. 100% of the patients had symptoms of anemia. 2 out of 6 of the patients presented during pregnancy, and about half of the patients had relatives with a similar diagnosis. And in terms of examination and radiographic assessment, 100% of them had jaundice, hepatic enlargement in 66%, cholelithiasis in 100%, and the average spleen size was 17.52 centimeters. Just looking at further lab results of the patients that we've had with hereditary spherocytosis, about 6 patients that we've had, the mean hemoglobin was 6.48, so this is WHO grade 4, severe anemia, an RPI average of 6, and a lactate dehydrogenase, again, the average of 1,948 in our patient population as well. Again, all patients were Coombs negative, and G6PD levels were normal in all 5 patients. Case 2. Case 2 is of a 58-year-old male with sober habits. So he was initially under the care of pediatrics and then later adult clinical hematology at Chris Hani Baragwanath Hospital. Initially, when he presented to us, he already had an established hematological diagnosis from childhood, from which he was on folic acid supplementation. In terms of his maternal history, he was born to a 17-year-old primary gravida, unsure of prior miscarriages. In terms of her booking bloods, she was rhesus positive, but syphilis was negative, and she had no history of preeclampsia, normal vaginal delivery. And there was a note in the file that she was suspected to be a heterozygote for a PK deficiency. In terms of pediatric history, in terms of neonatal history, he had a normal vaginal delivery. And at birth, in 1979, he had 3 exchange transfusions as well as phototherapy. And just incidentally had 1 culture which was positive for strep species, which was treated with ampicillin at that time. So further investigations. Just of note, hemoglobin was 8.4, the mean cell volume was 73, so it was reduced in this case. I was not able to find, unfortunately, other iron studies subsequent to that. Lactate dehydrogenase was more than 3,000, her tick count of 5.2, but otherwise G6PD levels were normal and was Coombs negative as well. So on peripheral blood morphology, this was from October 1979, you can see that he has a number of these elongated red cells, which again appear to be, in this case, quite numerous and occupy the morphology of elliptocytes. So upon further examination from the further tests from the South African Medical Research Council, there was no evidence of PK deficiency, and they had suspected that this patient that noticed it was alpha spectrum defect, and the later diagnosis based on these investigations was that of hereditary elliptocytosis. Again, with the concerns now in adulthood was on subsequent iron studies was a low serum ferritin and an iron deficiency, which was currently unexplained at present. So I'll now stop screen sharing for Prof. Kutsa to share her slides.
How do I? Okay. How do I go back with the slides? And it doesn't seem to work from my computer.
Prof, can you try the arrows on your actual laptop, left and right? And that should actually move the slides.
I'm trying them up and bottom and left and right, and they're not moving.
Do you maybe want to stop sharing and then reshare again, Prof?
Yes, let me do that.
Okay.
Okay, so I can share. It still doesn't. Let me stop sharing.
Don't go straight into presenter mode first. Go back to the initial slide and then start again. It might.
Okay. Okay, so maybe this is going to be it. So how do I move the... Okay. All right, sorry about that glitch. So good afternoon, everyone. And I'll be following on Dr. Garrick Lauden's talk, and I'll be explaining the molecular defects of the two cases he has just presented. So to understand this, we need to look at a model of the red blood cell membrane. Now, it looks quite daunting, but I'm sure all of you are familiar with this model. But in order to understand how these disorders arise, it's necessary for us to take a deep dive into this membrane. So let's start off by looking at the integral proteins and the lipid bilayer. So the lipid bilayer consists of phospholipid molecules, and the polar hydrophilic head groups face outward or inward into the cytoplasm. And in the center, you have the hydrophobic tails of these phospholipid molecules. Now, embedded in this bilayer, you've got so-called integral proteins. The main one is a protein known as band 3, which is the anion exchanger. So it can exist either as a tetramer as shown here or as a dimer. Now you'll see that band 3 is a transmembrane protein, so part of it sticks out to the outside, and you can see these tree-like structures extending out. Those are sialic acid residues, and they play a role in blood groups. Now, the major part of band 3 sits inside the membrane, and this is the anion channel. And the rest of the protein projects out into the cytoplasm. You also have other integral proteins of lesser importance, the glycophorins. So you've got glycophorin A as well as glycophorin C. So if we now look at the next part of the membrane, which is the membrane skeleton. So the skeleton is mainly composed of a protein known as spectrin. You've got alpha spectrin and beta spectrin. And these molecules are long, flexible molecules that intertwine around each other. At the so-called head region, two heterodimers get together in what is the spectrin self-association site. So these two heterodimers link up and form a tetramer. And the tetramer is the main building block of the skeleton. So at the tail ends of the spectrin tetramers, they are linked together by a junctional complex, which consists mainly of actin with some tropomyosin, tropomodulin, adenosine, and an important protein called 4.1. So protein 4.1 binds to beta spectrin as well as to the junctional complex. So 4.1 is critical for the spectrin tetramer tails to be linked to each other. So the next layer and the final layer are the so-called linker proteins, and they link the membrane skeleton with the integral proteins in the bilayer. The most important linker protein is aptly named ankyrin, and ankyrin binds to both the cytoplasmic portion of band 3, and it also binds to beta spectrin. And by doing this, it links, as I said, the skeleton to the bilayer. Protein 4.2 plays a role in this linkage of the two components. You also have another minor linkage, which is again protein 4.1. And this minor linkage occurs because, as we know, 4.1 binds to beta spectrin and the junctional complex. It also binds to glycophorin C with the help of a protein known as P55. But this is a minor link interaction. The main one is ankyrin. Then just another note, you have vertical interactions. So these occur along this plane of the membrane, and horizontal interactions which occur along the horizontal plane, in other words, in the plane of the skeleton. And these vertical and horizontal interactions will become important later on in the discussion. This is a very elegant electron micrograph of the red cell membrane skeleton. You can see it's this meshwork of proteins. Here is a higher magnification. And if we look at this annotated version, you can see that it's composed of spectrin tetramers. These big blobs are the junctional complexes, and you see some ankyrin stuck onto beta spectrum. Now, the skeleton is composed of hexagonal units. So you've got 1, 2, 3, 4, 5, 6. So 6 of these spectrin tetramer molecules link together to form a hexagon. And you've got other hexagons overlapping as well. Now, in the USA, they referred to this skeleton as a loosely knitted sweater. But I think the South African analogy is far better, namely that the skeleton is like a trellis-door. So we all know that trellis-doors protect us, and this is exactly what the skeleton does. It protects the membrane. The other aspect of a trellis-door is that it expands and contracts, and that's exactly what the skeleton does. It can expand and contract, and that flexibility allows the red blood cell to move through tiny capillaries and also to negotiate the tiny openings in the spleen. So let's have a look at HS. So the defects that occur in HS are primarily protein deficiencies. This could be any of the following proteins, either spectrin, ankyrin, a combination of spectrin and ankyrin, because if you remember, ankyrin is the main linker protein. So if there's less ankyrin, you can also have some of the spectrin falling off, and hence you also have less spectrum. You can also have a deficiency of band 3 or a protein 4.2. So for HS, the major problem is a protein deficiency. And this means that vertical interactions are affected. So if we look at our membrane model again, so in the red box, these are the vertical interactions. So you can see if you don't have enough band 3, so if you imagine that there's no band 3 here, you'll see that the linkage to the skeleton is not going to happen, and hence this part of the membrane will be unsupported. In the same way, if you don't have enough ankyrin, this interaction is going to be compromised. If you don't have enough spectrin, this isn't going to take place, and the same with protein 4.2. So these are all vertical interactions, and if they are compromised, you end up with spherocytosis. So let's look at the mechanism of spherocyte formation. So in this instance, you have less spectrin, so the membrane bulges out in that area because it doesn't have the proper linkage. That bulge eventually buds off in the shape of a microvesicle. So, and this microvesicle contains band 3 because it's a spectrin deficient patient. This membrane loss eventually leads to the formation of a spherocyte, and these cells are destroyed in the spleen. In the second instance, you have a decreased amount of band 3. So the spectrum content is normal, but because there's no band 3 in this area, this also bulges out and eventually buds off as a microvesicle. In this case, it does not contain band 3. Again, membrane loss leads to a spherocyte and splenic sequestration. So what about the pathogenesis of HS? Well, the primary defect is a deficiency of either spectrin, ankyrin, band 3, or protein 4.2. This leads to weak vertical interactions. This leads to loss of membrane in the shape of microvesicles. This then leads to a decreased surface to volume ratio, in other words, a spherocyte. These spherocytes have less deformability than normal biconcave red blood cells, so they are trapped in the spleen, and in the spleen, you have erythrostasis, and the environment is quite inhospitable because there's low glucose, low pH, lots of oxidants, and lots of macrophage contact. So these spherocytes, while they are trapped in the spleen, they are then destroyed. Some of them can continue and go back to the circulation, and then this cycle will continue. So what about some routine screening tests for HS? Obviously, you've got to look for spherocytes in the blood film, look at clinical and family history, markers of hemolysis and anemia, full blood count, and as was pointed out by Dr. Lorden, these patients have to be Coombs negative because you can get spherocytes in other conditions. But for it to be hereditary spherocytosis, the Coombs test has to be negative. There are also lots of tests based on decreased surface area to volume ratio. There's the osmotic fragility test, incubated osmotic fragility, glycerolysis, acidified glycerolysis, and the cryohemolysis test. Now, these tests are unfortunately not specific for HS. They just tell you that there are spherocytes. So what about additional screening tests for HS? Eosin 5'-maleimide, or EMA, this is a flow cytometry test, and this has gained quite a lot of traction recently. So EMA is a fluorescent dye. It binds to the transmembrane proteins in the band 3 macromolecular complex, and HS cells exhibit decreased fluorescence. However, other hemolytic anemias can also give lower values. There's no universal reference range and cutoff values like we have for other red cell parameters such as, hemoglobin, etc. And there's quite a gray area of overlap. So none of these screening tests that I've discussed or just mentioned detect all cases of HS. And laboratories these days typically use 2 tests. And the most commonly used ones are the EMA and the acidified glycerolysis test, because they seem to give the best results and seem to identify virtually all the HS patients. There are also specialized tests for HS. The first one is STS, polyacrylamide gel electrophoresis. It's still regarded as the gold standard. You isolate and you purify the red cell membranes. Then you separate the proteins by electrophoresis on STS polyacrylamide gels. You then can directly visualize and quantitate the red cell membrane proteins, and thus you can identify the defective protein. However, this technique is labor-intensive, it's technically demanding, and it's time-consuming. There's also osmotic gradient ectocytometry, which is used in a lot of specialized labs overseas. This monitors the red cell deformability under a continuous osmotic gradient and a known shear stress. But it's highly specialized equipment that's required, and it's actually very expensive. What about molecular genetic diagnostics? Well, whole genome sequencing is where you look at all the coding and non-coding DNA sequences, but this is far too expensive and you get lots of superfluous information. Whole exome sequencing only focuses on the protein coding sequences. It's less expensive, but also gives you lots of extra information that you don't really need. And it requires RNA isolation. You can't work from DNA. But what is happening lately now is that you have targeted next generation sequencing, or NGS. So here you have customized gene panels with relevant coding and non-coding regions of genes involved in the pathogenesis of HS. So if you're looking for HS, your gene panel would involve alpha spectrum, beta spectrum, ankyrin, band 3, protein 4.2, because those are the main culprits when it comes to HS. Now, for targeted NGS, you need stringent quality control criteria to ensure that you've got good sequencing quality. You have to do rigorous analysis of the data using various filters and software programs. And interpretation of novel variants is challenging. So if you do the NGS and you come up with a known variant that is known to cause HS, then you're fine. But if it's a novel variant, then it becomes tricky, especially in the South African context, because ethnic groups in Africa have poor or no coverage in international databases. The international databases are all set up using people from Europe and the USA. You also, if you have a potential pathogenic variant, you must confirm it by normal Sanger sequencing and also other tests. For example, you could look at the family. All the affected family members should have the same mutation, and all unaffected members should not have that mutation. And international guidelines have also now been published on the exact terminology that one has to use and how the analysis should be conducted. So let's move on to HE. In the defects of the RBC membrane proteins in HE is either a protein deficiency, and here the main one is protein 4.1. In a few rare cases, you can also have a deficiency, well, not also, but you can have a deficiency of glycophorin C. But typically, a protein 4.1 deficiency is one of the major causes of HE. You can also have protein dysfunction, and here the main cause is spectrin dimer self-association defect. In other words, the spectrin dimers don't self-associate, and hence the basic building block of the membrane, which is a spectrin tetramer, does not exist. You only have dimers, or you have more dimers than normal. If we look at a normal individual, more than 95% of the spectrum is going to be in the tetrameric form. You have less than 5% dimers. Whereas if you look at HE, you typically have around about 20 to 50% spectrin dimers. So that compromises the skeleton. This defect can be due to either mutations in alpha spectrin or beta spectrin, because both these molecules are involved in forming tetramers. Other defects include a truncated alpha or beta spectrin molecule, a problem with spectrin ankyrin interaction, or with protein 4.1 spectrin interaction. But all of these defects are horizontal interactions that are affected. So let's have a look at our membrane model again. So the horizontal interactions occur within the plane of the skeleton. So we have spectrin dimer self-association defects, So they can't link up, and hence they're just floating around and the skeleton is compromised. Or if you look at 4.1, if you have a deficiency of protein 4.1, so you don't have that linkage of beta spectrum to the whole junctional complex, so the spectrum tetramers aren't linked at their tail ends. And again, the skeleton is compromised. So this is an example of a blood smear of hereditary pyropoikilocytosis. And you can see the smear is completely messed up. And lots of spherocytes, microspherocytes, poikilocytes. It's very unusual. Now, the reason why the terminology was given of hereditary pyropoikilocytosis was because the initial investigators who looked at this first case felt that the blood picture was similar to a patient with severe burn wounds, and that's why they included the pyro in the nomenclature. So despite the fact that there is, if we look at the smear there, you virtually can't see any elliptocytes, but despite that fact, it is still classified as part of the HE spectrum of disorders, simply because of the molecular defects, because these patients have a severe spectrum dimer self-association defect. You're looking at like 60 to 80% spectrum dimers. So their skeletons are very weak and their membranes thus are very weak. And you also have a partial spectrum deficiency in all HPP patients. The inheritance is recessive, and the clinical presentation is of severe hemolytic anemia. And these little babies and kiddies are often transfusion dependent until they reach an age where they can be splenectomized. So in this case of HPP, horizontal and vertical interactions are affected. So if we look at our model again, the horizontal interaction that is compromised is spectrum self-association, where you have 60 to 80% dimers. So the skeleton is weakened. And you also have a compromised vertical interaction because you don't have enough spectrum. And as we saw from the HS side of things, as soon as you have a compromised vertical interaction, you end up with a spherocyte. And these two things combined explain the unusual morphology of the HPP case. Just a brief word about Southeast Asian ovalocytosis, or SAO. The smear is very characteristic, and you can see the cell in that red center, in the red circle. It's sort of a large oval-shaped cell and has that funny transverse ridge. So, as the name implies, it's widespread in certain ethnic groups of Southeast Asia. And interestingly, in my laboratory, we also found a lot of families that are from the Cape Coloured population. So if you have a patient from this population group and you see that characteristic red blood cell in the smear, then you really have to do a test because you could have an SAO patient. As we saw in the smear, the ovalocytes are sort of spoon-shaped. They have a transverse ridge, and the inheritance is autosomal dominant. And if you only have one copy of the bad gene, you're actually not severely affected. It's quite a mild condition. But if you're homozygous, then this is lethal in utero. Although there has been a recent, I think 1 or 2 cases described where there was intrauterine transfusion, and that sort of saved the baby, but it's still heavily compromised and very ill. In these SAO red cells, you find that the membrane is quite rigid, and they are resistant to invasion by Plasmodium falciparum and other species of malaria parasites. And that's the reason why this condition is extremely widespread in the low-lying areas of Southeast Asia, because of the evolutionary pressure of malaria. Because if you have SAO, if you have one faulty gene, then you are protected from dying from malaria. You can still get malaria, but typically you don't really get cerebral malaria or severe anemia. The molecular defect in SAO is a deletion of 27 base pairs in exon 11 of the band 3 gene. It's an in-frame deletion, so you have amino acids 400 to 408. They are missing, and they are at the cytoplasmic membrane boundary. So this change causes a conformational change in the band 3 protein. Now, in the case of the Cape-colored population, it is the identical mutation. So it is highly likely that this is due to a founder effect. In other words, an ancestor centuries ago came from Malaysia or other part of Southeast Asia and came to South Africa, and then the gene was propagated in this population. Now, the conformational change in the band 3 protein causes an increased binding to ankyrin, and it causes a decreased lateral and rotational mobility of band 3 in the membrane. Because all the integral proteins, including band 3, they are in the lipid bilayer, but they're not rigid and static. Everything is quite fluid, so they can move around. But in the case of SAO, this mobility is restricted, and these two things then make that the membrane becomes quite rigid and not as flexible as a normal membrane. There's also a decrease in the anion transport activity. So if we look at our model again, in SAO, this is the area where you have 9 amino acids missing, and that compromises the whole protein and affects the other interactions, and hence leads to that SAO condition. So what about some of the diagnostic tests for HE? Well, you need to look for elliptocytes on the blood film, although bear in mind that typically an HPP case usually does not have any elliptocytes. You need to look at clinical and family history, markers of hemolysis and anemia, and obviously a full blood count. You can also do protein studies for HE and HPP. So you can do SPS page of the red cell membrane proteins, and in that way you can pick up if there's a deficiency of protein 4.1, which will make it an HE. And if you have a deficiency of spectrin, then you need to consider that it could be an HPP. You can also do further analysis of spectrin for HE and HPP. So you would separate the spectrin, you would isolate it, and then you test the dimer-tetramer ratio on non-denaturing gels. And you can also do limited tryptic digestion of spectrin and subsequent SDS page analysis. And that will give you a closer, better idea of what the exact mutation is. So for SAO, it's actually very easy to diagnose because you can do a simple PCR and you can run your product on an agarose gel, and you can clearly see the 27 base pair deletion in the band 3. Because SAO, you're always dealing with a heterozygote, so you've got the normal band with a normal size, and then one that's 27 base pairs lower. So for SAO, if you have somebody from that specific population group, you've got those funny spoon-shaped cells, you can easily do a PCR to confirm that. Some specialized tests for HE, you can also do osmotic gradient ectocytometry, but as I mentioned with HS, this is highly specialized equipment and it's quite expensive. You can also do targeted next generation sequencing. And again, that's the area that the field is moving in. And here you would again use your customized gene panels, but now they would be specific for HE. So the proteins would be alpha spectrin, beta spectrin, and protein 4.1. Now, because you can customize these gene panels, a lot of people are now including other genes that code for minor proteins in the membrane. Because during today's discussion, I've just talked about the major proteins. But there are some cases that we haven't been able to identify the mutation, and those are probably because the mutations occur in those minor proteins. So the customized gene panels can be expanded to include other proteins as well. So that concludes my presentation. Thank you for your attention, and I'm now going to hand back to Anaemia, Dr. Anaemia.
Thank you, Prof. So case 3 is patient SM, so 14-year-old male with no known comorbid conditions. He has no travel history. He presented to a peripheral hospital in Gauteng with an acute history of yellowing of the eyes, as well as significantly dark urine, so Coca-Cola colored urine. He was seen in the emergency department, and it was noted that he had confessed to ingesting an unknown substance, which we are still to find out, which you'll find on the next slides, though. His childhood history was, unremarkable, and he had no past medical history of note. So in this slide, you're able to see that he was quite significantly jaundiced, and you can also see that he has quite significantly dark urine and does appear to be Coca-Cola colored as well. In further investigations, his hemoglobin was 8.1. Of note was his markedly elevated lactate dehydrogenase of 1,569, as well as a haptoglobin which was less than 0.10, as well as a predominant unconjugated hyperbilirubinemia. So you're probably wondering, the G6PD levels unfortunately were not done at that point. And the rest of the results in terms of Coombs was negative, and he had no other contributing examinations or investigations in this case. So a few days later, we then found out that he had ingested 14 naphthalene balls, so colloquially known as mothballs. And this will be an intro to another discussion later on in the talk about drug-induced hemolysis. So in summary, he was a 14-year-old male with acute hemolytic anemia, which was secondary to naphthalene ingestion.
Afternoon, everyone. So I'm just going to continue with these cases, and then my colleague and I, Dr. Loudon, are going to go through with an overview of hemolytic anemias, looking at the different aspects. So case 4 is of a 32-year-old female. She actually presented with a 2-week history of symptomatic anemia, fatigue, dizziness with associated jaundice. There was also associated weight loss of about 3 kilograms over the last 6 months. No other bleeding diatheses were noted on history. She didn't have any overt symptoms of any underlying connective tissue disease, and there was nil travel history, and there was no history of any medications or traditional medication use. On past medical history, she was previously admitted to Krisani Baragwanath 1 month prior to this admission with symptomatic anemia. She had received blood transfusions at that time and discharged. On that admission, she had a G-scope done that was otherwise normal, and an abdominal ultrasound that was done that was also otherwise normal. She's also recently diagnosed with retroviral disease, and she was started on ARVs 2 months prior, and she was virally suppressed on this admission, and no other previous opportunistic infections. She reported sober habits. There was no previous history of any venous thromboembolisms, and her gynae history was otherwise unremarkable. On clinical examination of note, there was evidence of scleral jaundice. There was also evidence of pallor, no noted lymphadenopathy clinically. She was hemodynamically stable, no overt skin rashes, and the rest of the exams were otherwise fine. Further investigations for her. So on her blood parameters, if you see on the FBC, she had quite a severe macrocytic anemia. Platelet count and white cell count with absolute neutrophil count were preserved, with reticulocytosis, lactate dehydrogenase levels were elevated, and the LFT showed a predominantly unconjugated hyperbilirubinemia with a slightly raised AST level. Her Coombs that was done from the actual blood bank, along with the direct that we had ordered from the lab, was negative ×2. And of note, her hematinics were otherwise okay, slightly raised iron, but it was probably done prior to post-transfusion. Okay, further investigations for her, the peripheral blood smear that was reviewed showed that she had both round and oval macrocytes with mild red cell agglutination and scanty spherocytes. Further tests showed that her hepatitis screen was negative, with a ANA that was also negative. Cryoglobulins were actually requested on her that was negative, and her bone marrow that was done showed that she had a hypercellular marrow with active trilinear hemopoiesis, with note a brisk erythropoiesis and no megaloblastic changes. Flow that was done on the bone marrow sample was negative. Of note, though, a PNH screen was done on her, and it showed quite a significant population, and there was evidence of a PNH clone, as you can see on the results shown on the right. Okay. So in summary, she was actually a Coombs negative hemolytic anemia, most likely dealing with a paroxysmal nocturnal hemoglobinuria. And moving on to case 5 was of a young lady as well, a 25-year-old female, She also presented with a symptomatic anemia, history of weakness, tiredness, and dyspnea, and jaundice at a peripheral hospital with associated fever and a background history of intermittent joint pains and stiffness. She could not quantify how long the joint pains and early morning stiffness were for. There was no associated alopecia or skin rashes, no noted photosensitivity or any oral ulcers. She was transfused 5 units of red pack cells at her peripheral hospital prior to transfer because she had originally presented at the local clinic where she had actually fainted. On past medical history, she was noted to be retroviral disease positive as well and started on antiretrovirals since November of 2021, for which she was compliant and regularly following up at her local clinic. There was no known travel history, no family history, no history of any traditional medications or drugs, be it over the counter or illicit, with sober habits. She had a gynae history of para-2 grav4, with 2 previous miscarriages at 8 to 10 weeks, no noted stillbirths, and 2 uncomplicated pregnancies via normal vaginal delivery, and no previous history of any venous thromboembolism. She was currently taking a Depo 3-monthly IMI injection. Of note as well, she was hemodynamically stable when we had seen her at our center. There was evidence of scleral jaundice and pallor, but of note, no lymphadenopathy, and all the other systems were grossly intact. Further investigations for her demonstrated as well a severe macrocytic anemia with a HB of 4, mean cell volume of 143.9, and preserved platelet count and white cell count with a reticulocytosis, high LDH with a low haptoglobin. Both her Coombs done at blood bank and direct were positive for both IgG and C3d, and she had a predominantly unconjugated hyperbilirubinemia as seen by total bili of 65 with a conjugated of 9 with a raised AST. Of note is that her ANA came back as positive with a titer of 640. It was homogeneous and speckled in pattern. She had a low C4 of 0.06 but a preserved C3, and a double-stranded DNA was negative. Her folate levels were also low at 7.1. Lupus anticoagulant that was done on her showed that it was 1.43 weekly positive, and a repeat was pending at the time. And the rest of her lupus anticoagulant screen with the anticardiolipin and beta-2 glycoprotein were pending. So peripheral blood flow that was actually done on her showed that there was no target population of note. And in summary, she's actually noted to be a 25-year-old female, background retroviral disease, on antiretrovirals, virally suppressed, now presented with a warm autoimmune hemolytic anemia, likely secondary to an underlying connective tissue disease, complicated by folate deficiency and possible secondary antiphospholipid syndrome. And then lastly, coming to our last case, is actually of a 21-year-old gentleman, and he had presented with a symptomatic anemia similar to the other cases that we have presented, with associated tiredness, dizziness, and dyspnea, with associated jaundice, initially at a private GP close to a peripheral hospital, and then was subsequently transferred to a peripheral state hospital. The initial smear that was reviewed at the private GP showed significant agglutination with some resolution on warming. He had developed a precipitous drop in his hemoglobin from the time of admission, where initially he had a hemoglobin of 11 and went down to a hemoglobin of 4 grams per deciliter. And it was with great difficulty that we were finding that any blood samples we were pulling at the peripheral hospital would easily clot, and therefore we were unable to get any FBC diff samples. Blood bank at this peripheral hospital was also having difficulty finding any compatible blood products. So in conjunction with discussions with Barra Hematology, patient was actually transferred across for better or optimal care. On inquiring further with conjunction with the family, the patient had actually reported a long-standing history of Raynaud's phenomena of his hands, his feet, and ears that would spontaneously come on and then resolve. Prior to this admission, there was no prodromal viral symptoms, there was no travel history and no history of medications or drugs, and no significant family history. He had occasional ethanol use socially, was otherwise a non-smoker, and he reported no previous blood transfusions reported. Clinically, he was noted to have some mild scleral jaundice as well, with significant pallor, but of note, he was actually hemodynamically stable, no noted lymphadenopathy, and no features of Raynaud's at the time when he was examined at the peripheral hospital, and the rest of his systems were grossly intact. So So these are actually some very nice pictures that he had very graciously assisted us with regards to this long-standing history where his hands and feet would actually change color, and these pictures were actually taken with the shared consent, with the patient's consent. So if you can see here, it comes on with regards to the complete discoloration and then spontaneously resolves. And he reported that this was on and off for the last 10 years. So further investigations done for him showed that, of note as well, similar to the other cases, he also had a significant severe macrocytic anemia with preserved platelet count, slightly elevated white cell count. Unfortunately, the retic count was not done. He had an elevated lactate dehydrogenase level, and he had a predominantly unconjugated hyperbilirubinemia with a raised AST. Of note, his IgG Coombs was negative, however, C3d was positive. However, his Sandbus Coombs was positive, that was subsequently done at Baragwanath. He had a low C4 level of 0.04. His ANA came back as positive with a titer of 80. However, his double-stranded was negative. His retroviral screen, hepatitis screen, and syphilis screen had all come back as negative, and he had a slightly elevated immunoglobulin level of 2.74, and hematinics were otherwise minus the ferritin, but he had received blood products when this ferritin was done, was elevated. So further investigations, the bone marrow that was subsequently done showed an active hypercellular marrow owing to the erythroid hyperplasia with no overt evidence of any lymphoproliferative disorder of note or any infiltrates or any lymphoid focus. The flow cytometry that was done showed no target population, and at the time of the actual presentation, serum protein electrophoresis was pending, as was the rest of the viral serology panel and cryoglobulins. So with him, he's actually, in summary, a 21-year-old male, background, long-standing history of Raynaud's, now presents with cold antibody autoimmune hemolysis secondary to most likely cold agglutinin disease. So we're actually going to move on to just looking at, I will cover an overview of hemolytic anemias, and between my colleague and I, Dr. Loudon, we're going to chop and change and cover all these aspects of these interesting cases that we've actually presented. Autoimmune hemolytic anemias, it's pretty much when function becomes dysfunction in the sense of immunology. The host immune system reacts against its own red cell antigens, hence the term auto. There's antibody binding and complement activation. There's a thermal range of the antibody binding, be it IgM versus IgG. And it's a decompensated acquired hemolysis. Generally, the direct antiglobulin test, the DAT, is positive. However, there are some diagnostic dilemmas that exist, which my colleague Dr. Loudon is going to elaborate on subsequently in more slides. And the etiology can be divided into either primary or secondary. So if we look at it, it could be also with regards to divide up, be it immune versus non-immune. Under the non-immune, the three main groups looking at would be infections, chemical and physical agents, and fragmentation. Under infections, intracellular organisms could be falciparum malaria, endotoxin-induced such as meningococcal sepsis, hemophagocytic syndromes, HIV can also be there, enzyme toxins such as Clostridium perfringens, whereas under chemical and physical agents, heat osmotic lysis can be one of the causes. And then fragmentation, lysis of your red blood cells on prosthetic surfaces, such as your cardiac valves, with a fibrin shear mediated response that can be seen with microangiopathic hemolytic anemias. Take-home message from this is to actually not to forget the non-immune causes, such as your microangiopathic hemolytic anemias, which in these settings will actually be Coombs negative. It can also further then be subclassified into either, or a different way of class, autoimmune versus alloimmune. Under autoimmune, we can look at either warm antibody versus cold antibody, and I'll cover the cold aspect, whereas Dr. Loudon will cover the warm aspect, whereas Dr. Loudon will cover the cold. Under warm, it can be divided into primary and secondary. Primary mainly being idiopathic with no overt causes known, versus secondary. Common causes or associations can be autoimmune conditions such as systemic lupus erythematosus associated with rheumatoid arthritis, or commonly under lymphoproliferative neoplasms or certain infections, and sometimes even associated with drugs. Then under alloimmune, as you can see, it could be induced by red cell antigens, such as is seen with hemolytic transfusion reactions or hemolytic disease of the newborn, or it could be drug dependent, where there's an antibody macrophage mediated or antibody complement mediated, or due to membrane modification or autoimmune in itself. So with regards to a diagnostic algorithm when we're dealing with autoimmune hemolytic anemias, it's actually a nice algorithm that we had come across. For the sake of time, we can actually read through it in our own leisure. So I'm going to skip through because we have quite a lot of slides to get through. But I will be, if you just look at the, okay, I'll be dealing with the autoimmune hemolytic with the warm aspect. If you are dealing with it and you get a Coombs that's IgG only, most likely dealing with a warm autoimmune hemolytic anemia versus the other aspects that my colleague is going to deal with in subsequent slides. Okay, then with regards to the direct globulin test, the standard direct globulin test, the DAT, demonstrates IgG and or complement, usually C3d, which is bound to the red cell membrane. Antibodies bind to the red cell membrane. Bound to the red cell membrane may be IgM or IgA, but an extended panel to determine these will have to be employed. Whereas the indirect globulin test are assays of antibodies in the serum that by incubating the patient's plasma with the test red blood cells and the anti-human globulin that then leads to agglutination. So some of the diagnostic dilemmas that exist in building a diagnosis is sometimes there's no clear diagnostic consensus or classification criteria. Studies define that both DAT positive and DAT negative autoimmune hemolytic anemias exist. DAT is neither sensitive nor specific, and a Coombs negative makes up to 2 to 6% of all cases. Chronic lymphocytic leukemias associated with autoimmune hemolytic anemias may actually be DAT negative, and they may not require the presence of red cell antibodies or steroid responsiveness. I'm going to give over to Dr. Loudon, who's going to further go on to drug-induced hemolysis.
Okay, so as illustrated in the case that we presented previously with the 14-year-old gentleman who ingested naphthalene, again, it's probably a rare cause of hemolysis, but just to know that naphthalene occurs generally with so it's an aromatic hydrocarbon, and it's found in mothballs, deodorizers, and insecticides as well. So generally it induces hemolysis in patients who happen to be G6PD deficient. It's one of the agents that we should avoid. But even in patients who are not deficient in G6PD, it's still able to induce hemolysis. And that's by, again, depleting the glutathione stores and the generation of reactive oxygen species. Just to note that with naphthalene-induced hemolysis as well, or with ingestion, is that the approach to management is generally supportive. Unfortunately, I didn't have the methemoglobinemia or methemoglobin results in this patient, but if the methemoglobin level is above 20 to 30%, it generally requires specific therapy with intravenous methylene blue. And again, that's highly effective, but again, methylene blue is also contraindicated in severe G6PD deficiency. Just to be aware of that, I mean, these items are ubiquitous in households, but as little as the ingestion of 2 naphthalene-containing mothballs can result in quite severe hemolytic anemia as well as hypotension. Just look at the aspect of drug-induced hemolytic anemia is that, again, the number of drugs is increased. So it's a rare entity, and then more than 150 drugs are implicated. In 1967, that there were only 13 drugs that were implicated. In 1980, 32 drugs were implicated. And then in 2007, there was reasonable data to suggest that up to 125 drugs were implicated. And you'll see that the patterns of drugs that are implicated changes as time progresses. So initially, methyl-dopa is regarded as one of the prototypical drugs, but because its use became less and less, it's now less implicated in terms of drug-induced hemolysis. So there's, with antibody-mediated mechanisms of immune hemolysis, there's drug-dependent, and that's usually when the antibodies are detected in the presence of the drug. So for example, with cephalosporins, and again, the implication of cephalosporins as one of the drugs causing drug-induced hemolysis is now on the increase, probably as a result of its increased use of the cephalosporins. Then drug-independent antibodies. So again, antibodies do not need to be present in order to obtain in vitro reactions. And that's with, you'll see with fludarabine, which we commonly use in chronic lymphocytic leukemia. So again, as I mentioned, historically implicated drugs, so methyl-dopa and penicillin, and now in current times, cephalosporins, your piperacillins, as well as NSAIDs are implicated in drug-induced hemolysis. So there's a few mechanisms that are implicated in terms of how hemolysis takes place. So again, in column A, you'll see that the antibody binds to the drug. So again, the covalent binding of the to the red blood cell membrane and the proteins. And then again, the red blood cells become coated with the drug in vivo. And then the drug antibody, which is usually IgG in nature, then attaches to this drug-coated red blood cell. And this then causes these drug-coated red blood cells to be subsequently cleared by the macrophages in the reticular endothelial system. Whereas if you look at, say, for example, in C, that's when there is the combined membrane together with the drug surface creates an immunogen. And this then creates the formation of antibodies, which can be either IgM or IgG. And this again, via IgM, can either activate complement, resulting in acute intravascular hemolysis, and sometimes acute renal failure from the hemoglobinuria. Then the last column, again, the not pictorially depicted here, is that drugs appear to be have the ability to modify the red blood cell membrane so that proteins become non-immunologically absorbed onto the red blood cell membrane, thereby altering the red cell, the membrane itself, and then inducing the formation of antibodies. So if you look at prototypical drugs, so in terms of A, that would be penicillin, alpha methyl-dopa. In terms of B, so that's when there's antibodies to membrane components. C, creating this three-way or ternary structure is usually your third-generation cephalosporins. And then again, not pictured there, but the ones that modify the red blood cell membrane, cephalotin is one of the agents. And then just be aware that, again, there's quite an exhaustive list of drugs that we should avoid in hematology, specifically in porphyria and G6PD deficiency. So I think just to learn and be aware of some of the common agents that cause hemolysis in G6PD deficiency. So it's everything almost with an anti. So anti-malarials, anti-pain medications, so analgesics, antibacterials, and then again, being aware of your naphthalene or mothballs and henna, as well as methylene blue, and then the favor beans as well. So I'm going to hand over to Shani just to hemolytic anemia.
So moving on to warm autoimmune hemolytic anemia, it can arise spontaneously, be it primary idiopathic or in a setting of conditions or medications that predisposes to production of an autoantibody. The autoantibodies are typically polyclonal pan-agglutinins directed against common red blood cell antigens. So autoantibodies are almost always IgG. However, in certain cases, they can be IgA and warm-acting IgM. Of the IgG subtypes, there's the IgG3 and G1, and they're most able to fix complement, leading to more destruction. Warm antibodies are usually directed against the red blood cell antigens, commonly being the rhesus complex of antigens, and secondly, the glycophorin antigens. This leads to red blood cell destruction, causing extravascular hemolysis within the reticular endothelial system, and there's also hepatic destruction through macrophage phagocytosis of red blood cells coated in complement. And in the spleen, it can happen through cytotoxic T cells that destroy the red blood cells, and also through macrophages in the spleen via the Fc gamma receptors that recognize and phagocytose the IgG heavy chain and a portion of the red blood cell membrane, leading to the spherocytes. Intravascular hemolysis may be seen in severe cases if the reticular endothelial system becomes overwhelmed or if the complement membrane attack complex is deposited on the red blood cell surface. So with regards to just some basic terminology, If we talk about warm autoimmune hemolytic anemia, it's the IgG antibody usually that is active at normal body temperature. If we're dealing with warm agglutinin, it's the anti-red blood cell antibody that is active at normal body temperature. And antibodies rarely cause agglutination of red blood cells in vivo with the IgG 2 valences and cannot bind more than 2 red blood cells at a time. And agglutination will occur with the Coombs test. Whereas plan agglutinin, it's an antibody that reacts with all reagents of the red blood cells. And the warm autoimmune hemolytic anemia, there's alloantibodies that usually react to specific red blood cell antigens, such as the CAL or the KID. And the cold agglutinins often have specificity against little I or big I, which I think we're going to cover later in subsequent slides. Okay. And with regards to investigating secondary causes for a warm autoimmune hemolytic anemia, big groups to look for would be viral infectious. Most commonly implicated in our setting would be HIV, Epstein-Barr, also hepatitis C and hepatitis E virus, underlying autoimmune disorders such as lupus or rheumatoid or ulcerative colitis, and then another big group would be your lymphoproliferative disorders, chronic lymphocytic leukemia, quite well known and implicated, lymphomas and monoclonal gammopathies such as multiple myeloma, or an MGUS, monoclonal gammopathy of undetermined significance, also not to forget Waldenstrom's macroglobulinemia. And then also certain immunodeficiency states, inherited immunodeficiency state versus acquired, such as in a hematopoietic stem cell transplant setting or in a solid organ transplant setting, and then certain causes of hypogammaglobulinemias. And then other big groups would be the pregnancy and drug associated. Note that the presence of warm autoimmune hemolytic anemia may precede the diagnosis of a lymphoma by either months, if not even sometimes years. Okay, certain signs and symptoms to look for. Most always commonly is anemia-related symptoms. As you've seen in all the case discussions that we've had, pretty much all of them presented with symptomatic anemia or anemia-related symptoms. 75% of cases present with this with associated jaundice. Splenomegaly is seen in approximately 1/3 of cases. And note that the splenomegaly may be due to an underlying lymphoproliferative disorder as well. And the chest pain is usually brief with episodes of hemolysis. Okay. And for the sake of time, we opted to keep the overview of management of warm autoimmune hemolytic anemias down to one succinct slide, because I think that could be a conversation all on its own. But if you look at the algorithm here, very nicely done from up to date, is to look at if you're suspecting a warm autoimmune hemolytic anemia, first thing is to ask yourself, how severe is the anemia? Are we dealing with any concerning symptoms in that is the patient symptomatic with concern or cause for severe anemia with a hemoglobin of less than 7 going up to 8 versus no concerning symptoms? If that is the case, initially stabilize the patient and provide whatever support necessary, be it in the form of hemodynamic or ventilatory support. And then initial management after stabilization would be to review and rule out any underlying causes. So review medications, discontinue any that might be associated with or causing a drug-induced autoimmune hemolytic anemia, review any underlying conditions and initiate therapy as appropriate, review any possible alternative diagnoses such as cold agglutinin disease, screen for any underlying deep venous thrombosis or pulmonary embolism. If inpatient and or severe hemolysis, provide, most importantly, folic acid supplementation during active hemolysis. As we had noted in one of the cases, the patient was actually folate deficient, and start with glucocorticoids with or without rituximab. So quite a few of the cases have actually opted for glucocorticoids in conjunction with rituximab, unless there's any overt contraindications to rituximab in our setting being concomitant active hepatitis B. And then if there is recovery after 2 to 3 weeks with the hemoglobin returning to baseline and the markers of hemolysis diminish, then slowly consider tapering off the glucocorticoids with extended monitoring between intervals, and if not, reevaluate for any second-line therapy. And plus minus, consider adding another medical therapy or discuss the possibility of splenectomy. Okay, I'm going to pass over. There you go.
Thank you, Shani. So let's just look at the spectrum of cryopathic disease. So that's cold agglutinin disease, your paroxysmal cold hemoglobinuria, as well as cryoglobulins, which, and again, you'll see that with cryoglobulinemia, there's no associated hemolysis. So just know that the cold agglutinin disease, again, has a prevalence of about 5 to 20 cases per million, and an incidence of 0.5 to 1.9 cases per million per year. And it shows, again, considerable variation with climate. And again, that the cold agglutinin disease generally accounts for about 15 to 30% of cases of autoimmune hemolytic anemia. So just look at primary cold agglutinin disease. So again, primary cold agglutinin disease, also called idiopathic, is usually generally referred to cold agglutinins that cause red blood cell agglutination and extravascular hemolysis in the absence of an underlying disorder. So again, it's the other definitions of it is that it's a primary cold agglutinin occurs in the absence of associated disorders, with the exception of a B-cell clonal lymphoproliferative disorder, but without overt, so that's clinical or radiological evidence of a malignancy. So there is still an underlying aberration of the B-cell or B-cell clonal lymphoproliferative disorder, but without evidence of overt clinical disease or radiological disease of that malignancy. Secondary cold agglutinin syndrome is, again, when cold agglutinins arise in the setting of an underlying disorder, such as a viral infection, an autoimmune disorder, or a lymphoid malignancy. And again, this would be an overt lymphoid malignancy in terms of clinical features or radiological features. Then the Doneth-Landsteiner antibody I'll get to in a subsequent slide, but again, it's an antibody which is able to recognize the antigens on red blood cell membranes at cold temperatures. But unlike cold agglutinins, it doesn't fix complement and then only causes hemolysis when in the circulation. Sorry, these antibodies fix complement and then only cause hemolysis in the circulation. So there's generally two phases of the disease, the cold phase and then the warm phase. And again, patients have symptoms associated with hemoglobinemia and hemoglobinuria. And again, antibodies are usually IgG, and they're often directed against the P antigen, which is on red blood cells. And then, as I've mentioned, cryoglobulins, that they are generally antibodies that form immune complexes in the cold, and they don't generally interact with red blood cells, but they can cause a systemic vasculitis, a systemic inflammatory syndrome, or vascular occlusion, but generally no associated hemolysis. So just the basic pathogenesis of cold agglutinin disease is that generally the autoantibody is IgM as opposed to IgG. In this diagram, you'll see IgG is associated with warm, IgM is associated with cold. And with the pentameric nature of IgM, that hemolysis is particularly complement dependent and is able to fix complement intravascularly. And then you can have extravascular hemolysis of your C3b opsonized cells, and this then predominantly occurs in the liver. And this again has implications for therapy. So generally, splenectomy is not favored in these patients, as most of the extravascular hemolysis occurs within the liver itself. So just to look at complement in cold agglutinin disease, again, if you look at the classical pathway, you'll note that the IgM binds the red blood cell in cold temperatures. And then again, it binds either I, so small I or large I on the red blood cell surface. So little I is for little people, so in pediatric patients, and big I is for big people, so adults. And then IgM recruits components of the classical pathway, so C1, C4, and C2. And then ultimately your C1 esterase will then activate C4 and C2, and this leads to production of C3 convertase. So C3 convertase converts C3 to C3a and C3b. And again, everything that's generally associated with B is generally is an opsonin. So it opsonizes the red cell, and C3a mediates inflammation. And again, the C3b coated red blood cells are then phagocytosed by macrophages in the reticular endothelial system. So that causes extravascular hemolysis, and that's predominantly, as I mentioned, in the Kupffer cells of the liver. So splenectomy in these patients produces few, if long-standing results. So again, the phagocytes will tend to engulf the entire cell rather than a portion of the cell membrane, and therefore less spherocytes. You then have C5b, which then initiates the terminal pathway, so your membrane attack complex of C5b, C6, C7, C8, as well as C9. So looking at paroxysmal cold hemoglobinuria, you'll see that, again, this is an IgG antibody, so it's biphasic, meaning that it works at two different phases or two temperature amplitudes. So again, at low temperatures where it would bind and then causes hemolysis at 37 degrees Celsius. And then usually the Doneth-Landsteiner antibodies are produced usually as a result of an infection. So the prototypical disease was luetic disease or syphilis, viral infections, and then again non-syphilitic. And then generally, it occurs in children, sometimes transient. And then again, it's then able to bind complement C3d, binds to the Daneth-Landsteiner antibody, and this then causes red cell lysis within the circulation, so intravascular hemolysis. So this is, I think we've pretty much referred to the basics of these diseases. So again, paroxysmal cold agglutinin, and cryoglobulinemia. What's common to all three of them is, again, looking for underlying lymphoproliferative disorders or neoplasms, autoimmune disease, and infection. And then, again, the take-home message from here is that paroxysmal cold generally reacts with the P antigen, and it's cold-reacting IgG that is polyclonal and does not cause red blood cell agglutination. So that's your prototypical Daneth-Landsteiner antibody, as opposed to cold agglutinin disease, which reacts with either I, big I, or small I, and it's a cold-reacting IgM. And these IgM, they're either monoclonal or polyclonal, and they do agglutinate red blood cells. And then just to be aware again, that cryoglobulinemia is not associated with hemolysis. This is just another infographic which basically summarizes cold agglutinin or cryopathic disease in one slide. So again, cold agglutinin disease you can see is either primary, secondary. When it generally is secondary or secondary causes with overt, say for example, overt B-cell lymphoproliferative neoplasms, autoimmune conditions, that's when you would call it cold agglutinin syndrome. So that's when cold agglutinin disease occurs with an underlying disease. And you'll notice that everything that's listed in purple here is what's associated with hemolysis. So cold agglutinin disease, paroxysmal cold, as well as cold agglutinin syndrome are associated with hemolysis, as opposed to cryoglobulinemia, which is not associated with hemolysis. So again, in yellow here is the antibodies that the antibody binds to. So in the case of cold agglutinin disease, it's IgM with its pentameric structure. So it either binds to little I or big I, and then this causes, if it does cause intravascular hemolysis, this is within the reticular endothelial system, particularly the Kupffer cells of the liver. And then paroxysmal cold hemoglobinuria, that would be your Daneth-Landsteiner antibody, which has this dual thermal ranges. So it binds in cold, but causes hemolysis in warm temperatures, and that's IgG mediated. So again, looking at the patterns of positivity is that generally with cold agglutinin disease, it's usually anti-C3. So you may have these patients with who are C3d positive and IgG negative. So again, looking at a basic diagnostic pathway is that, again, you look at the composite of your laboratory investigations as well as your clinical picture of your patient. So you again look at the typical laboratory features, which are your raised LDH, your bilirubin and unconjugated hyperbilirubinemia, a low haptoglobin, and an increased absolute reticulocyte count. So again, in a review of about 61 patients, the most common definition or commonly used definition for autoimmune hemolytic anemia was that of a positive, or one with a positive DAT. And then the second most common definition was that of a hemolytic anemia with a positive DAT. And then what Shiny had referred to initially was the element of a DAT negative autoimmune hemolytic anemia. And that again was defined on red blood cell directed antibodies. And so, I mean, we obviously don't routinely test for other red blood cell antibodies which could induce hemolysis. But again, this is quite widely described in CLL. And in these studies, generally the presence of a DAT negative autoimmune hemolytic anemia, they replace this definition with a positive DAT, and it's replaced by reticulocytosis and other markers or other laboratory markers of hemolysis. So again, your composite of a raised LDH, raised unconjugated hyperbilirubinemia. And then again, just to define the phase of the disease itself. So again, chronic disease, so again, generally that's for more than 6 months. Newly diagnosed disease within 3 months, and then again persistent from 3 to 12 months from diagnosis, and then chronic, which lasts more than 12 months. So again, it kind of mirrors some of the definitions or the terms that are used in ITP as well. So again, cold agglutinin disease, we use a number of building blocks to define the definition. So DAT, that's positive, so usually mono C3d positive or polyspecific. The titer is important, so a titer of a cold agglutinin more than 64. The cold agglutinin thermal amplitude or range up to 30 degrees Celsius. and then the cold agglutinin specificity for anti-I on the red blood cell membranes. So important disease definitions and terms is that the thermal amplitude generally correlates with the degree of disease severity in cold autoimmune hemolytic anemia, and it's correlated with the intensity of complement activation. The higher temperature at which this antibody is able to react tells you the greater ability to fix complement, and therefore the greater or ensuing damage that occurs on red blood cell membranes. And again, cold agglutinins with a thermal amplitude higher than 28 to 30 degrees Celsius are generally regarded as pathogenic. Then there's a cold agglutinin titer, is generally the inverse of the highest plasma or serum dilution at which the agglutination can be seen at a given temperature. If we look at the severity of anemia and cold agglutinin disease, so again, there's a number of papers which differ on their severity of disease. So there's one paper that defined severe as a hemoglobin less than 6, not maintained by daily transfusions, and extremely severe was a hemoglobin less than 3, and then very severe in other papers was defined as a hemoglobin less than 6, and severe with a hemoglobin of 6.1 to 8. So just to note that hemoglobin levels generally correlate with the mean values of lactate dehydrogenase. So again, you'll see that with severe anemia, you'll see a mean LDH of 534, as opposed to someone who, for example, had a mild anemia with a mean LDH of 385. So if we look at treating cold agglutinin disease, again, if you have someone with a suspected cold agglutinin disease, it's important to look at particular triggers and underlying disorders that may be implicated. Again, you define the need for treatment based on how rapidly you need to institute treatment. So again, you can use one or more of the following in order to rapidly induce treatment or treat these patients. So again, using red blood cell transfusions, using blood warmers, sutimlimab, so targeting your complement, as well as plasmapheresis. And again, the other underlying treatment modalities are based at treating the underlying B cell clone. So again, using your rituximab, bendamustine as well, in order to treat or target the underlying B cell clone. So in summary, in terms of the treatment is, again, beware of the cold. So symptom awareness, being aware of the acrocyanosis, Raynaud's, being aware of gangrene, which can occur less often, and to keep the patient warm and to rewarm. Remember, supportive treatment always with warm blood and plasmapheresis. Again, banishing the B, that's important to initiate B cell directed or B cell depleting therapy. So what else is missing? So again, complement or complements of the season rather, is again targeting the complement pathway, either targeting the complement pathway more distally or more proximally, which I'll get to in the next slides. So again, the prototypical diseases in which complement therapies were generally of use in terms of treatment was paroxysmal nocturnal hemoglobinuria, as well as your atypical hemolytic uremic syndromes. So just to be aware that there's the classical pathway, lectin pathway, and the alternate pathway. So again, using agents like eculizumab, this targeted the pathway generally more distally, and this targeted more C5. You'll see in the next slide that the complement inhibitors and inhibition tended to look at targeting the complement system more proximally. So using sutimlimab in terms of targeting C1. So again, the efficiency of your anti-C5 therapies has been well demonstrated in PNH, but using agents like sutimlimab, which is a humanized monoclonal antibody, this targets your C1s protein. And again, patients who receive this in your cold agglutinin disease generally have experienced improvement in the hemoglobin and the bilirubin levels, as well as fatigue. So other studies have suggested that a potential benefit of eculizumab, again, in using it in cold agglutinin disease, and using sutimlimab as a bridging strategy until you can use B-cell directed therapy with rituximab, or until it takes effect. Again, the downfalls of using complement inhibition is that it generally does not improve the cold-induced circulatory symptoms, which are themselves not complement-mediated. For the purposes of time, I just want to summarize some of the findings that we've had in terms of local data from Chris Hani Baragwanath Hospital in terms of our autoimmune hemolytic population. So again, in a summary of about 51 patients, again, the mean age is between, the mean age was 36, and again, with a slight female predominance. So again, interesting to note that patients in the Barrett cohort were generally diagnosed in their 3rd to 4th decade of life, which is similar to other studies we were conducted in other resource-poor countries such as India. And the postulate for the younger age at presentation and female preponderance is again attributed to the major contribution by HIV and then the peak frequency of disease in the 3rd and the 4th decade of life. So again, you'll see the clinical presentation of patients with autoimmune hemolytic anemia at Krisani Baragwanath Hospital. Again, most of them presented with the triad in terms of their presentation. That was anemia, that was jaundice, and then features of splenomegaly. So again, anemia tended to be more severe in this cohort. You'll see that the mean hemoglobin was 4.84. And this was in part owing to multifactorial other causes of anemia in our patient population, which is again in part due to nutritional deficiencies, TB co-infection, as well as other opportunistic infections. If we look at the etiology of autoimmune hemolytic anemia in our population, the majority of cases were secondary in nature, and the etiology of our population was similar to that described in mainstream literature. However, secondary was again more common, and the major contributor to secondary autoimmune hemolytic anemia was HIV. And this is unlike the Western world where CLL and autoimmune disease contributed to the majority of cases. A study from Nigeria, just interestingly, of 98 unselected consecutive adult HIV positive patients, noted that about 3% of them met eligibility criteria for defining autoimmune hemolytic anemia. Although we didn't touch much on the role of HIV in terms of autoimmune hemolytic anemia, patients who are infected with HIV are more likely to have positive direct antiglobulin tests without symptomatic disease in about 20 to 40% of patients, but without overt hemolysis or disease. With HIV infection present in about 88% of patients, in this population, only 3 patients had a CD4 above 350. And in this study, there wasn't statistically significant correlation between the CD4 cell count and the anemia severity. If we just look at the next slide, that the majority of patients were treated with prednisone in the first line, and those who did not show a good clinical response by the 3rd week were then started on azathioprine. And just to note that in patients who are HIV positive, that the initiation of HAART is a part of the treatment. But just interesting to note that a study from Taiwan in patients who were autoimmune hemolytic anemia positive, as well as HIV positive, that those who received HAART were more likely to develop an autoimmune hemolytic anemia, and particularly those who were on efavirenz or atazanavir. And this was, they had postulated that HAART initiation leads to an increased number of CD4 positive T lymphocytes and again enhances T cell mediated immunity in these populations. If we look at treatment response, that treatment response evaluated HB initially and serially at 3 weeks. And then this revealed a mean hemoglobin increment of 3.7 grams per deciliter at around 3 weeks. And then even with good incremental response at 3 weeks, only 11% of the patients had hemoglobin that was above 11. And this suggests that, again, these patients had a much lower hemoglobin at baseline, and therefore took a much longer time for this to rise above 10. The mean time to partial remission in this population, again, was about 14 weeks, and primary patients had a shorter time to remission as compared to those with secondary. And the mean time to remission for patients with primary was about 39 weeks. And there was death in 5 patients, 3 of which had HIV with concomitant opportunistic infections as well. And that brings us to the close of this talk.
Thank you very much to all the 3 speakers for a well-researched and well-presented talk as well. There are a few questions on the chat box. Okay. First question is, what do you do for patients who definitely have hemolysis and all tests inherited and acquired have come back negative? Rita's answer that could be a Coombs negative autoimmune hemolytic anemia. Any other suggestions, Shiny or Garrick?
I would say that I agree with Dr. Govender. I think that, again, although not a well described entity, is the Coombs negative autoimmune hemolytic anemia. So just because we're not able to find other red blood cell antibodies, again, that may be because of access or our ability to find them, doesn't mean that they don't exist. So I think again, it's rare. And it's described in chronic lymphocytic leukemia in terms of DAT negative autoimmune hemolytic anemia. So I think that is, I agree with Dr. Govender on that point.
I also agree. The question is sometimes it's idiopathic, so it'll take time to actually elucidate a cause before you can treat. I think the next question is for Prof. Coetzee. Thanks for the great overview. Is SDS page available locally?
I'm not sure because I haven't kept up with what has been happening, but my research lab used to do it, but I don't have my research lab anymore because I've retired. And yeah, I'm not sure if any other facility offers it.
I also am not aware because we haven't requested the tests at all. We are running out of time, so the next question was, do you routinely confirm the presence of cold agglutinins and obtain cold agglutinin titers for patients with cold autoimmune hemolytic anemias? Can I answer and say that we don't routinely confirm it? It's only when we do not find a secondary cause that we then go ahead and look for it. Moses says, do you think the last patient you presented has CAD, which is essentially a clonal disease according to WHO, or secondary CS? Garrick, for CAD, how do you prove clonality?
So I just want to answer Moses's thing. So I mean, the definitions are a bit difficult, but again, cold agglutinin disease. So again, it says that is an underlying B cell, lymphoproliferative or B cell clonality, but there's no overt disease. So either radiologically or clinically. That's just in terms of the definition. So I think that possibly the patient may have had Shiny's patient may have a cold agglutinin disease, but we're not able to overtly prove that he has any, secondary causes. So there's no obvious or overt radiological disease of lymphadenopathy or anything to suggest it's underlying lymphoproliferative neoplasm. I don't know if you agree, Shiny.
Yeah.
And then for the diagnostic tests, again, I think proving clonality would probably be, from the start, from the, bone marrow biopsy, immunohistochemistry, the pattern of infiltration that you're able to assess on the morphology. If there's any flow cytometry analysis that proves that this may be a clonal neoplasm, I think it errs more on the side of find an underlying cause, and then in terms of the treatment, so again, anti-B cell therapies that target your B cells, as well as targeting your more long-lived plasma cells with other B cell therapies, so bortezomib, as well as your daratumumab as in terms of future therapy. And then any data or response.
Thank you very much, Garrick and all. Moses, we can talk separately. Thank you all. We've actually gone way past that time. Well, not way past, but we have gone past that time. Thank you, all three of you, for wonderful talks, for simplifying it and making it easy to understand. And I wish everybody a good evening. Please do not forget to complete the survey that comes on as you leave this talk. Thank you all again.
Thank you, Dr. Philip, for chairing, and thank you, Prof. Coetzee, for having you on the talk. It was really, really great to have you, and thanks, Shiny.
Yeah, thank you, everyone.
Thank you. Thanks, everyone.
Thank you. Bye-bye.
Good night. Bye-bye.